Thank you very much. I'm delighted to be here. I'm impressed with the turnout tonight. I dare say most of you are here tonight because either you or a loved one has been told that you have a leaky heart valve. And I'm here to tell you that for most of you, no, maybe even 99% of you, you really don't have anything to worry about. The most important slide is the next slide. This slide has everything that will be on the final exam. After this slide, everything else is just fluff and pictures. So here are the most important points. Number one, if your leaky heart valve, if your valve is leaking because of a disease, even severe mitral prolapse, this is usually a chronic, lifelong, and hardly ever serious problem. If your leaky heart valve is not due to a disease, don't worry. Probably don't have to worry about number one either. So how did this ever happen? Well, 80% of us have some normal valve leakage detectable on echocardiography. 80%. And you know this is true. You know why it's true? It was published in the New England Journal of Medicine, so it has to be true. So why are leaky heart valves reported so commonly on echocardiogram reports? It's so the doctor can get paid. And so you can come back next year and get another echocardiogram and the doctor can get paid again. Because if the doctor keeps writing down normal echocardiogram, Medicare's not going to pay them. So, I told you this was the most important slide. And the reality is, if you haven't been told your whole life that you have a heart murmur, and every time you were in a big medical center, they didn't call in the medical students to take a listen and teach at the bedside, then you probably do not have anything like a serious heart valve problem. So, that's the most important thing I can tell you tonight. Let's get on with some fun, okay? Well, what are these valves? What is this business with valves? Well, to understand what the valves do, you have to understand a little bit about the heart. And here's a surface picture of the heart. And the surface anatomy shows us where the ventricles are, which are really muscular chambers, the atria, which are like booster pumps, and the large veins in blue and the large artery. And what's the largest artery in the body? The aorta. Oh, gosh. I guess we can finish. So, to understand how the heart works, you have to understand its physiology, its function. And here's a description of the circulation. The heart is actually a pump. Blood comes to the right atrium from the body. And this is blue blood. It's not blue because it's aristocratic blood. It's blue because it's oxygen poor. The oxygen's already been extracted from it because you were exercising, for example. And then it goes through the right side of the heart, and it's pumped from the right atrium into the right ventricle, pumped from the right ventricle into the lungs where it picks up oxygen and then turns bright red. And it returns to the heart and then gets pumped to the body. So the right heart pushes blue blood to the lungs. The left heart pushes the red blood to the brains and the organs for life. And all in all, the heart in cross-section looks like this. It's really a composite of four muscular chambers, the two atria and the two ventricles. The ventricles are really the main pumping chambers of the heart. What we're going to talk today about are the valves. The valves, there's an inflow valve and an outflow valve for each of the ventricles. So in total there are 4 valves, 2 in the right heart, 2 in the left heart. We'll use some terms, and I may forget to call it a leaky valve, but I may call it a regurgitant valve. So regurgitation is a leak, and stenosis is caused by scarring. So scarring is stenosis. So that we're all using the same language. We're going to keep our language clean tonight. So here are the 4 valves. On the right side of the heart are the pulmonary valve and the tricuspid valve. We're not going to talk about these tonight. These are valves that are affected most often by congenital heart disease, like blue babies. And I think that's for a different age group than all of us, including myself. But the left heart contains the aortic valve and the mitral valve. We're going to focus on those. Here's a top view of the 4 valves. Each has 2 or 3 thin folds of tissue. And you can see here's the mitral valve, the famous valve for mitral valve prolapse. Here's the aortic valve. It has 3 folds of tissue normally, although some people are born with 2 folds, and that makes that valve more prone to develop narrowing, scarring, or leaking. The pulmonary valve is like the aortic valve. It has 3 folds. And here's the tricuspid valve. These are on the right side of the heart. So what is the purpose of the valves? Well, when these muscular chambers, the ventricles contract, they force blood to move out toward the lungs or toward the body. And the outflow valve opens and allows the blood to move forward, and the inflow valve closes, and it prevents sloshing, regurgitation of blood back into the atria. So when the chambers contract, the blood moves through the heart, and the valves prevent backward motion or sloshing of blood back into chambers where it doesn't belong. There are a couple different types of diseases that cause valve leaking and scarring. Sclerocalcific degeneration is a really fun term to say, but really what it means is wear and tear. It's wear and tear. This is the process that leads to valve scarring after 60, 70, 80 years of age. Myxomatous degeneration, that's a medical term for prolapse. And then there's rheumatic fever. Remember rheumatic fever? It's pretty much gone now. It started to disappear by the late 50s, and it started disappearing even before antibiotics were in wide use for streptococcal infections. But we still saw rheumatic heart disease in the 80s and 90s to some extent, and nowadays it's very rare. Coronary artery disease, which can cause heart attacks, can cause some valve problems like leaking of the mitral valve. Enlargement of the heart can cause the valves not to function correctly and to leak a little bit. And then endocarditis is fortunately, a very rare cause of valve problems. It's really an infection on a heart valve. And many of you who have leaky valves may have had to take antibiotics when you went to the dentist. You don't need to do that anymore. Since 2007, it was pretty much realized that the antibiotics you took for going to the dentist didn't prevent endocarditis at all. It was such a rare condition, and you probably were just at as much risk of getting endocarditis just from brushing your teeth. So you're not going to stop brushing your teeth, or you're not going to use antibiotics every time you brush your teeth or floss or use a water pick. So they recognized that we were really going overboard, excessively so, by recommending antibiotics. The only people who need antibiotics now when they go to the dentist are those who've had prior endocarditis or had a heart transplant, or if you have an artificial valve. So, if you have endocarditis, you know it is a very serious illness. It's 100% fatal without long-term antibiotic therapy. So it's not one of these conditions where you would think back and say, gee, I wonder if I had endocarditis. You would know it. It took a year out of your life, and you were in the hospital for a long time. It's leaking of the mitral valve. It occurs when the mitral valve does not close correctly, allowing blood to leak back into the left atrium. And I think there's a little arrow on the slide now. It's very commonly reported on the echocardiogram, usually produces no symptoms, but when it's really severe and it knocks the doctor's socks off every time he listens or she listens with a stethoscope to your heart, it may be significant enough to cause chronic fatigue or shortness of breath. The treatment would be mitral valve repair for really severe symptomatic mitral regurgitation, and that's a surgical procedure. But I dare say that only 1% of you in this room who have been told that you have mitral regurgitation have anything that would be considered severe. It might even be less than that. So that's good news, isn't it? So what's the business? What's going on here? When with all of us being told we have a little bit of mitral regurgitation, you got to come back next year. Well, I don't know. The way I look at it is maybe we do too many tests. Well, there's nothing wrong with tests that are like this. I mean, it's pretty harmless. Put a probe on the chest, Now look at this incredible picture. I mean, this is the left ventricle contracting here. This thin structures the mitral valve. I mean, it's mesmerizing. There's nothing doctors like to do more than a lot of tests, you know. So you can't blame us for wanting to, look at your heart every year. And here's the left atrium back here. So this is a normal mitral valve. Here's one with a little bit of thickening on it. That would be considered mild mitral valve myxomatous degeneration. A little bit of prolapse is occurring here. And so this is an ultrasound test. Again, showing the left ventricle over here, the left atrium there, and this white structure here bobbing back and forth is the mitral valve in action. Doppler is this color flow, wonderful appearance here. Now, pure red and pure blue is blood flowing either toward you or away from you. When you see this sort of mixed variegated color pattern, these yellows, greens, teals, kind of psychedelic, that's turbulent blood flow, and that's a sign that there might be some leaking. And this is the amount of leaking we see in a normal person. So when the doctor sees this amount of leaking, oh, mitral regurgitation is present. Mild to moderate. See you next year. And here's a little more leaking, a little more vivid yellow, green, and teal. Here's another view. In this type of test where they put the probe down your esophagus after you're sedated to suppress your gag reflex so you don't vomit all over the doctor. Things are a little backwards. The left atrium is at the top of the screen, and the left ventricle, the main pumping chamber, is at the bottom. So this is the little bit of mitral regurgitation, that colored jet right there. And that's considered mild, but it's probably totally normal. Totally normal. Here's a strange thing. I saw this in a journal. So this is the mitral valve right here, but this round circle that's bobbing back and forth is a vascular structure called a varix. It's like a varicose vein on the valve. And I guess it has to be removed with surgery. I've never seen a case like this before. And here, it's actually below the valve. It's not causing any leaking or anything because the red and the blue are pretty much normal. But surgical excision is probably recommended. But it is a pretty cool picture. The way you can determine if somebody has really severe mitral regurgitation by an echocardiogram is to actually record one of these four findings. There's something called the vena contracta. The width has to be more than 7. I won't go through these because it's not going to be on the test. But there is a way to quantify whether somebody on an echocardiogram actually has severe mitral regurgitation. We can do it in the heart catheterization laboratory where I work. Feldman and I and Von Miriam, Hahn and Santoyan, we all work in the cath lab at Munroe, and we have ways of assessing how severe mitral regurgitation is. But at the big academic centers, they can do it using this method, and it's fairly reliable, not as reliable as heart catheterization, or I would dare say not even as reliable as this, my stethoscope, but don't let me forget it. But the reality is, I have never seen any of these things reported in a single echocardiogram report at any time in Marion County. Either no one has severe mitral regurgitation or it just, no one knows how to measure it. Some people have artificial valves, and they produce a slightly different appearance on the echocardiogram. More bright echoes, a little bit of leaking, and here's another picture of an artificial valve. This one, unfortunately, is in a patient who has endocarditis. They have an infection on their artificial valve, and the infection has destroyed the sutures, the stitches that hold the valve in place. And so you're seeing this wild rocking motion of the valve, and this time, I would even agree with all that color up there that there's severe mitral regurgitation. So endocarditis is the condition in this particular case. While we're talking about the mitral valve, I'm going to take a little excursion off to the side and talk about the most common arrhythmia in Americans, and that is atrial fibrillation. And the big question that comes up in atrial fibrillation is who needs anticoagulation with Coumadin or warfarin, which actually is a component of rat poison, but it's not really a poison. It makes rats bleed when they eat too much. And who can be treated with aspirin? Well, this is called the CHAD score. This is how doctors calculate somebody's risk for having a clot that may cause a stroke and therefore may need warfarin to prevent a stroke. We use the CHAD score. CHAD is an acronym. It stands for congestive heart failure, C, hypertension, age greater than 75, diabetes. You get 1 point for any of these, and you get 2 points for the S, stroke or systemic thromboembolism, if you had a prior clot caused by atrial fibrillation. So your doctor should, if you have atrial fibrillation, and actually about 9% of people over 80 do, and it's considered pretty much normal, and it can happen in any age group, you should ask your doctor what your CHAD score is to see if you really need Coumadin, because the risk of stroke goes up with the higher CHAD scores. The risk of stroke is less than 1% per year if your CHAD score is 0 or 1. It's about 1% at a CHAD score of 2, and it's over 5% if your score is 6. And I've seen some reports showing that it might even be higher than 10% with a CHAD score of 6. Well, why don't we put everybody on Coumadin? Well, it's a pain. Coumadin's a hateful drug, and it can cause bleeding. So the chance of bleeding on Coumadin in a major way, in a life-threatening way, is about 1% per year. So why would you use a treatment that's more dangerous than the disease? So now I'm teaching you how doctors think, right? We don't try to use treatments that are more dangerous than the disease. And if you have a CHAD score of 0, you should be treated with aspirin and not with Coumadin. If it's 1, you have a choice. If it's 2 or higher, then Coumadin makes sense. And it's for this kind of thinking that we've come up with this scheme. We'll change gears here a little bit and talk about aortic stenosis. This is a wear and tear condition of the aortic valve. It's caused by scarring, or my favorite term, sclerocalcific degeneration. And when it causes symptoms, it may be fainting on exertion, not just fainting out of the blue, but fainting when you're running to catch the bus. We don't do that too much anymore. Running upstairs or something. It may cause shortness of breath or angina, which is chest pain. It can be diagnosed very accurately with my friend here, the stethoscope. And other ways to diagnose it include the electrocardiogram, the echocardiogram, and heart catheterization. It may require valve replacement if symptoms occur. Patients who have aortic stenosis, but no symptoms, they feel perfectly well, no fainting, no chest pain, no heart failure, don't need any kind of operation or surgery at that point in time. And that's the nice thing about aortic stenosis. It's the nice thing about all valve problems. In medicine, we've scared all of you about the silent killers out there. The silent killers. You might have something that could get you any day, but valve disease is not like that. It's not like that at all. In fact, with aortic stenosis, perhaps the most serious valve problem, you can go for 60, 70 years with the condition without any symptoms at all. And the only time your outlook for the future changes, your prognosis, your risk of having a serious problem changes is when you get the symptoms. It doesn't happen just out of the blue. There's virtually nothing catastrophic about valve disease, short of that problem with endocarditis, which is rare, and fortunately, we have good treatments for it nowadays. But if you have symptomatic aortic stenosis, there are a couple different types of valves that can be used to replace your valve. There are tissue valves, which are called bioprosthetic. They're made out of porcine tissue, porcine pericardium, or porcine valves, pig valves. And I understand it's okay to use them if you're Jewish and Orthodox. It's a medical thing. There are also some made out of cows. But when I was an intern 32 years ago at UCLA, I had a patient who was an artist, and he had aortic insufficiency. And he needed a valve. And he said, I don't want a pig valve, I don't want a cow valve or a metal. Why can't I have a greyhound valve? That didn't make it, unfortunately. Then there's the metal valves, mechanical valves. They're made out of carbon and titanium. And something like the St. Jude valve, I think it's been around for about 24 years and it's still going strong. It's a great valve. We have a new approach to treating patients with aortic stenosis that doesn't require open heart surgery. Two of my partners, Dr. Hahn and Dr. von Meering, are able to put in catheters and insert valves through catheters in patients who are too sick to have surgery. And this was approved by the FDA last year, and we've done a handful of patients, all successfully, no complications. So there's actually hope on the horizon for patients who would even be considered high risk for surgery to have this valve as well without having the chest cracked open. So there are new advancements being made all the time. ARDIS patient when I was an intern, also known as aortic insufficiency or aortic valve leaking, and it's due to weakening of the aortic valve, preventing complete closure, may be seen on 19% of totally normal echocardiograms, but it's only significant in 5 out of 10,000 patients. So in all of Ocala, there might be 25 people who have significant aortic insufficiency, but there are probably 20,000 who've been told they have it. So that gives you the ratios. When it's severe, it may cause shortness of breath, and when it's severe and causing symptoms, it may require valve replacement. Mitral stenosis, this is of historic interest basically nowadays because this was the condition that was caused by rheumatic fever. And rheumatic fever was a northern disease. North of Tennessee or so, it was moderately commonly seen. It was seen in the UK. The average age of onset of rheumatic fever was about 12 years old, and then an average of about 19 years later, patients started getting scarring of the valve. But most of the rheumatic fever patients actually are no longer with us. That was from an earlier era, and so we hardly ever see mitral stenosis anymore. Basically, the end of the rheumatic fever era was the 80s and the 90s. When it occurs, the valve does not open fully. It causes blood to back up into the left atrium and the lungs, causing difficulty breathing or atrial fibrillation. This was an interesting, here's a rheumatic valve right here, narrowing, and the normal valve is right here. So there's not much ability for the blood to get through that valve into the left ventricle. This was an example of some of the earliest surgical attempts, which were absolutely courageous. At a hospital in Boston called Peter Van Brigham, they did 5 surgical procedures on young kids with this problem in 1923. Before they had open heart procedures, they didn't have cardiopulmonary bypass, and one actually did very well, but when 4 in a row died, they put it off again until about 1947, and then took it up again, and it was quite successful after that. So, very interesting history. Now, to wrap up, I'm going to talk about a condition called broken heart syndrome. It doesn't have anything to do with valves, but it's kind of interesting, and it's something that we're recognizing more and more recently. If somebody has a severe emotional stress, loss of a loved one, gets fired from their job by their boss, or even gets a fright about a possible medical diagnosis, they can end up with a condition that, for all intents and purposes, looks like a heart attack. We can take them to the heart catheterization laboratory, find that all the arteries are open, and find as well that the heart contracts in a very peculiar pattern. The tip of the heart balloons out, so it's also called apical ballooning. And I guess when the heart contracts, it looks like something that the Japanese used to catch octopuses. So they call it an octopus pot cardiomyopathy, and I guess that's a Japanese word for octopus pot. So I didn't just teach you heart disease tonight, I taught you Japanese, takotsubo. Here's another way of looking at it. This is MRI. This is a normal heart here on your left. And then this is somebody with takotsubo on the right if it contracts. There we go. So the pattern's quite a bit different. But we're recognizing this more and more. It doesn't require any specific therapy. I mean, we often use aspirin and beta blockers, but patients get better on their own in a matter of 2 or 3 days to a couple weeks. And it doesn't require a stent, a balloon, or bypass surgery. So that's just another little tangential topic here. So wrap up by saying the take-home messages tonight are that most leaky valves are totally benign. Antibiotics are not required any longer for most patients with valvular heart disease when they go to the dentist or if they get a colonoscopy or any kind of other medical procedure like that. And one reason we have this epidemic of leaky valves out there is because we do so many tests. But I want you to remember that medical tests themselves do not prevent disease. We overtest and we overtest. Tests will take you from being a normal person and make you into a patient. But you have to ask yourself, would I rather just be a person? So thanks for your attention tonight.